Alright, guys. I hope you can all hear me. Alright. Sorry. Just wait. We were just waiting for everyone to join. Um, Welcome to this session, everyone, and I hope you're going to enjoy. So, just to let you know, this is an interactive session. So you'll be able to raise your hand, and Olivia will pick you if you have your hands raised. And also, you can turn on your camera, but please know that this session is recorded and will go on our YouTube. So if you do turn on your camera, it's at your discretion. But it's also a very good thing, so then Olivia can give you non-verbal feedback. Um, there will be certificates of attendance, and to be able to get them, you need to stay until the end of the session so that you can have the link to the feedback form. Yeah, hope you guys all enjoy.
Can you see my screen? So I can't tell if my screen's obvious or not. Oh no, you can't see my screen. Hold on. Can you see my screen now? Okay, great. So, just to introduce myself, what we're going to be doing today is going to be an interactive session. It's a bit of teaching and also just providing some feedback on any answers. So, just an introduction on who I am. My name is Olivia, and I'm a third-year medical student from Keele University. And my experience in interviewing has been quite a lot. So, I've been helping with aspiring medics tutoring for about 3 years now, and every single person has got at least one of their offers, and I've tutored over 400 medical students now. So I'm very experienced in that sense, and I'm so excited to deliver a talk for you guys, and hopefully you guys can learn as much as you can. What I'll be doing is just going over some common structures for questions and also a bit of practice too, just so you guys can get used to speaking and also receiving feedback, because feedback is so important. Feel free to connect with me on LinkedIn as well if you haven't already. And if you have any questions, feel free to put it in the chat too. So in terms of the structure, you will have a lot of questions that are very common for interviews. And your main three common questions will be motivation questions, ethics questions, and data interpretation questions. And we're thinking about an MMI here because if it is panel, you won't tend to have data interpretation questions or any role play as well. But for MMI, you can get anything. So, in terms of motivations, the question will be, could you please tell me about a time where you have demonstrated a value? And I'm sure you guys have had teaching on this before, so I'm not going to go too much into detail. But in terms of the structure I'm looking for is I'm looking, have you defined the value in question? So if it's communication, have you defined what communication means to you? Then you need to speak about a specific problem where you have to use that value. So, for an example, I'm a volunteer in a care home, and I used communication to solve a problem I had in the care home. So, you must talk about the context of your scenario and any roles and responsibilities that you had in your role. Then you have to speak about the problem. It has to be a specific problem that you faced during that time. So, for an example, was a problem where a resident didn't engage in activities as much? Or do you feel like one of the residents weren't eating as much and there was a problem there? So how did you exactly fix the problem? And this question, we test your ability to reflect. So you can use a STAR technique or you can use this technique. But in reflection, you need to think about what went well and how you could improve. So in the scenario, did you feel like you could have done anything differently? What do you think went quite well? And the main points that you get here is linking it back to medicine and dentistry. So this links back to medicine because communication is an essential skill for doctors. You've got different types of communication, like non-verbal and verbal forms of communication. So you must link it back to medicine too. So in your motivation question, you can use your work experience, your volunteering, any extracurricular situations too. But the main thing is we're looking at, can you reflect in a structured way? And when you're reflecting, are you honest with your reflection? Like, is there, for example, when you're reflecting on a scenario, you must be honest in what you could have done differently. Then we go to any ethics scenarios, and there are so many ethics scenarios that could possibly come up, and it's very hard to memorize answers for all of them. But you can use general guidelines. If it's a child in the question, we can check for safeguarding. Safeguarding can include forms of abuse or any sort of drug misuse. Capacity really varies in children as well compared to adults. Capacity is the ability to make decisions. And then confidentiality, when do we break confidentiality? So we can break confidentiality when we believe there's a giant risk to the public compared to themselves. And the most common question where you have to break confidentiality is in the HIV scenario. So where a patient has been diagnosed with HIV and they don't want to tell their partner. You've got the 4 pillars of medical ethics, which is autonomy, beneficence, non-maleficence, and justice. And those are really good pillars to use in terms of structuring your answer here. You've got the ICE framework, which is ideas, concerns, and expectations. You've got a lot about the GMC and the MDT too. So you've got a lot that you can include in your ethics questions. And what we're looking for is, it's not necessarily the right answer, but it's more about how you structure your answer and whether you're using the relevant guidelines. Then you've got the data interpretation question. And the way you come to data interpretation questions is by basically treating it like a GCSE maths question. So when you get a graph in front of you, look at the title of the graph, explain the type of graph, the X and Y axes, because those are very, very simple things that you can get marks for. Explain any trend that you can see. Is it correlation or causation, the reliability of the graph or the source of the graph even? So that's data interpretation. With role play, the main bit for role play is breaking bad news, and you can use a spikes framework for that. But I've been told that you guys have been taught this already. There are loads of keywords that you must use in your answer too, because keywords get you a lot of marks. So patient-centered care, you can use that keyword anywhere, GMC guidelines, the NHS core values. You don't need to memorize all the NHS core values, maybe just 1 or 2 that you can include in your answer. The Equality Act, which has 7 characteristics that can protect people from discrimination. The biopsychosocial approach, and what that means is when you have a patient, you don't look at them just medically. You don't look at them in the sense like, what can I diagnose here? You need to think about the diagnosis, any psychological elements or any social factors as well. For an example, if you've got a patient and you're giving them treatment every single day, how is it going to affect their work or their family? The duty of candor, that's the duty of honesty. So whenever doctors or dentists make mistakes, they must be honest to the patient. And then we spoke about capacity and confidentiality. QALYs is quality adjusted life years, and we can use this framework to see whether an intervention is beneficial to a patient or not. And quality adjusted life years is, for an example, if I'm giving this intervention to a patient, how many extra years can I add on to that patient's life? And are those years satisfactory? You know, are they independent? Can they do things themselves? And about the psychological state as well. So these are some keywords that you can use. Marking. So what are actually examiners looking for? We're looking for body language and tone of voice. That goes a really, really long way, because if you're sat here and you're just speaking your answers and you're not using your arms, it will seem very robotic and memorized. And body language goes a really long way in forming that rapport with the interviewer. It's important that you're aware of the relevant guidelines and the principles. So for an example, the GMC guidelines or the NHS core values and principles, that's the very basics that you must know. You must have a very good structure of your answers, especially in the reflection questions too. And it's important that your answers are very concise too, because sometimes people can go off topic. Always bring it back to the topic. When we're speaking about hot topics, it's very important that the hot topics are balanced. So you don't just give pros, you also give cons. So for example, if it's abortion, why should abortion be illegal? And then why should abortion be legal? So you must give both sides to it. And you must come to a conclusion. You must not sit on the fence in the hot topics. As long as you can make a conclusion and you can back up the reason that you've made this conclusion, you will get the marks. And you don't get marked down for stuttering or taking time to think about the question. If anything, they really enjoy when you do take time to think about the question, because it shows that you're actually thinking about what you're about to say and you're not just diving into the deep end. So that's all my teaching. It's not a lot of teaching because I know that you guys have already had sessions before. So the way that this is going to run is I'm going to ask you guys a question, and if anyone wants to answer, if you could just put your hands up, and then I can pick you. And it would be great if you guys had your cameras on as well, like the person speaking, so I could also comment on body language. Um, does anyone have any questions regarding the teaching so far? Any questions or any interview questions that you've seen that you just don't really know how to answer? Sorry, I'm just checking the chat. Uh, so please let me know if you have any questions, but so far I think it's all okay. So we're gonna go with the first interview question. Could you please tell me about a time where you have demonstrated communication? So who wants to answer this question? You put your hand up. And you don't need to be scared if you're gonna get it wrong, because I promise there's no wrong answer here. Could you please explain what QALYs are again? QALYs are quality adjusted life years, and we use that in the organ donation scenario. So, for an example, if you've got an organ and you need to decide between two people who to give an organ to, you can look at the quality adjusted life year. So, if I give it to patient A, how many extra years would the organ give that patient? And it's also about the quality of those years. So if we give an organ to someone and they're bedbound and they're not independent, they can't do anything for themselves, then their qualities would be a lot lower. And then it would not be worth giving the intervention to them. And for an example, if it was patient B and we give qualities, and their quality is very high, they have a high quality of life in the extra years that they have from the organ, we can give it to them. So qualities is sort of a calculation method that you can use when you're in doubt on whether to give an intervention to a patient or not. Because it's not just about how long someone lives, it's also about the quality of that life that someone does live. Sorry, I missed it. Did you say with hot topics have a conclusion and don't sit on the fence? Yes, absolutely. I've seen so many students that just sit on the fence because they don't really know the right or wrong answer, but there's not a right or wrong answer here. You must make a conclusion, and as long as you can back it up with logical reasoning, then you'll have no problem. So, for an example, if it's about euthanasia and whether we should legalize euthanasia or not, then you can think about the reasons we should legalize euthanasia. So all about autonomy and ensuring patients have the right to choose the way that they're treated. Or we can have cons where the duty of a doctor is regarding the health of the patient and not speeding up someone dying. Or religious beliefs that some religions don't believe that doctors should be involved in speeding up someone's death. What are some common hot topics that they could ask about? They could ask about AI, obesity, antimicrobial resistance, global warming is a big one, any challenges facing the NHS, COVID-19 they like to ask too, but it's more about the long-term impacts of COVID-19 rather than the short-term impacts. What would you say yeah, that's most important hot topics? What kind of case studies can we use for hot topics? So case studies can be the main ones I know of, or that you guys should know of, is the Andrew Wakefield case, where basically Andrew Wakefield was a very respected healthcare professional that linked the MMR vaccine to the increased risk of autism, and then loads of people didn't take the vaccine. And now, unfortunately, the rise of measles, mumps, and rubella are on the rise at the moment. So that's another problem because there was actually no link between measles, mumps, and rubella and autism. The mid-Staffordshire crisis is a great one to learn about because a lot of things went wrong during that crisis, where a lot of patients died because of the lack of care that doctors and nurses gave to the patients, and that's because of burning out and lack of resources. So that's a really good one to include in any answer or any NHS challenges, basically. Okay, so yeah, so who would like to answer? How far back in time can hot topics go? It can go quite far back, to be honest, but they would usually focus on anything that is currently relevant in time. So I know the assisted dying bill is quite relevant at the moment. Junior doctor strikes are quite relevant. They can ask you about that, but they wouldn't go too far back in time, if that makes sense, because they prefer what's relevant at the moment. Okay, so the first question, could you please tell me about a time where you've demonstrated communication? Rumi, go for it. Let me just time your answer.
All right. Well, that time was when me and my team were doing this science competition, and well, I had to delegate roles to everyone because everything would overlap in the end. So we had to like communicate on what each of us wanted to do and decide what we would focus on. So uh, well, I didn't. When I use communication, I wasn't like telling them orders or anything. I was just saying, what would you like to do? What do you want to focus on? One of them wanted to focus on the diet, problems. The other wanted to focus on more scientific data, rather. And I just wanted to focus on the conclusion and the final idea. So that was one time that I used communication. Uh, yeah, it's 5 minutes. I'm like,
Anything else to add?
um, no, not really.
No, okay. Don't worry. This is kind of it's quite a difficult question, but it's the most common question that you will get, and probably you will most likely get it. So when you're talking about time by the time where you've demonstrated communication, you need to make sure that you define the value first. So what does communication mean to you? So it can be that, the exchange of information between two individuals and the different types of communication. In terms of the context and the scenario, you explained it quite well, in terms of what actually the scenario that you had to use communication was. But the main thing is you must link it back to medicine. If you don't link it back to medicine, then you'll lose a lot of marks. So doctors have to ensure that they have very clear and concise communication, especially when speaking to patients. They can change their tone of voice and their non-verbal communication to ensure that they're building upon the patient-doctor relationship. When you speak about the context as well, you must reflect upon what went well and what could you have done better, because you need a lot of reflection in that question to speak for 5 minutes. It's an MMI station, so you must speak for a bit longer. So yeah. So define the question, the context, the problem that you faced, how you can solve that problem using your communication skills, and then what you could have done better, and then link it back to medicine. You must link it back to medicine. And when you link it back to medicine, you can include the GMC guidelines or the NHS core values as well. So that gives you extra points when you use those key points. Any questions, Rumi?
Um, when you say like GMC guidelines and stuff, what would you say?
So yeah, you can say one of the GMC guidelines or even one of the GMC domains is about communication, partnership, and teamwork. And the GMC tells us that we must ensure that we have high quality of care to patients. And one way we can do that is by ensuring that we have very clear and honest communication to the patients. But other than that, we can also have very clear and respectful communication towards our colleagues and members of the multidisciplinary team. It's important that we treat everyone with respect and uphold professional relationships. So it doesn't have to be something so detailed, but you must link it back to medicine or just even drop the word GMC guidelines in there. You'll get a lot of marks.
Thank you.
That's okay. At each station, is it one question or two or three? It depends on how long you speak for. If you speak for a long time and it's completely relevant on topic, you won't get follow-up questions. But sometimes if you speak and it's off topic, then they will ask you follow-up questions. Or if you speak and it's almost like a perfect answer, they will cut you off early and ask you follow-up questions. Interviewers like cutting people off early, and it's not a bad thing because sometimes they'll know that the answer you're about to give is an amazing answer, so they want to challenge you a lot more. So if you do, it just kind of depends on the university and the interviewer really, but they're not forced to ask follow-up questions. Some unis anyway, so it's very variable. Any other questions? Okay. The next question is, why would you like to apply to this university? Does anyone want to answer that? And it can be any university you've applied to. So put your hands up. Anyone want to have a go? Yeah, don't be scared. I don't fight. It'll be really good practice for you guys as well. Okay, if you want, I'm happy to sort of give you the structure on how to answer this question. So, how you would answer this question is by talking about the academic side of medicine and the non-academic side of medicine. So, in the why would you like to apply to this university, you can speak about the curriculum, whether it's a spiral curriculum, whether it's PBL-based curriculum as well. So, PBL stands for problem-based learning, and that's when you all speak about a patient case and you work together as a team to come up with a diagnosis. You can speak about intercalation, where you can take a year out after year 2 or year 4 to pursue a master's degree. Or you can even speak about any early patient contact or clinical exposure. And that's really good because at the end of the day, you guys are going to be graduating to become a doctor. So it's very important that you have that early clinical exposure. A lot of people also like to speak about how anatomy is taught in those universities. So whether it's cadaveric or whether it's prosection, that's very important. Cadaveric is when you have a full body on the table and you can dissect the specific organs that you are studying. And a prosection is when you have those specific organs right in front of you without actually needing to dissect them. Then you need to speak about the non-academic side. So that's about societies, locations. So what society would you like to join and why? In terms of location, where is it located? Is it a campus-based university or a city-based university? And because that will differ because campus-based, everything is quite accessible in one spot. So that can be quite convenient. Whereas city-based, it can be quite busy. And if you're someone that enjoys that busy area, that's definitely for you. Aren't most universities cadaveric? No. Actually, most are prosections. I think there are only 3 universities in the UK that do cadaveric dissections. And the reason being is because the facilities to hold cadaveric dissections are very expensive and not a lot of universities do. Kiel does, yes. That's why I very much enjoy the Kiel curriculum because like I'm dissecting all the time. I'm looking at those organs. I'm actually seeing how it is in the real human body. I know there are universities like Lancaster that does virtual anatomy and the anatomage table. So they're all a bit virtual, but most universities do prosections and some do cadaveric. Also, if a uni focuses on some rural med rotation, yes, so you can say that the university has placements in rural areas, and that's really interesting to you because a lot of medical students don't have exposure to rural health, and that's really important because there are loads of health inequalities that are present in rural areas. So you can just say that you would really be interested in going to those placements because a lot of conditions that you find in rural areas are very, very different to urban areas. So for an example, a big one is zoonotic conditions. So because a lot of people in rural areas, they can work with animals, a lot of their conditions from animals can transfer to humans. And a lot of doctors don't know how to treat that, or medical students have never seen that. So that can be a very interesting placement. Cadaveric is when you have the whole body in front of you and you can dissect the parts that you want to look at. And prosections is when the body has already been dissected by a professional. So it's usually an anatomist or like a surgical, and they just give you the organs instead. So you don't actually see the body that it came from, you just see the organs. Now, the advantages with cadaveric is you can see the relationship between different organs. This is not related to interviews, but ultimately, does it matter which uni you do med at? No, it doesn't really. I personally like a lot of people have asked me, but med is med everywhere. Now I know a lot of people have different opinions on like the teaching curriculum, and it's very important that you do go to a university that you do enjoy the curriculum with. Because for an example, Kiel, they stagger their exams, whereas I know places like Lancaster, they like have the final exam right at the end of the year, and I would have much preferred having staggered exams rather than one whole exam at the end. So it does actually matter to an extent whether the teaching style is something that you enjoy. But at the end of the day, med is med, and you will graduate with the same degree. So any other questions? Which 3 unis do cadaveric? Glasgow does cadaveric, Kiel does cadaveric. I have a feeling that Imperial does cadaveric as well, and I think about UCL actually, so it might be 4. But they change all the time because facilities can be quite hard. It's very expensive because they have to monitor the formaldehyde levels in the air and stuff like that. So it's very difficult for unis to actually do cadaveric. So no problem, no problem. So the next question is, why would you like to study medicine? So Anyone have a go or even put some ideas into the chat? Yes, I can read the thing. This is very variable question. Like you can really say anything. Oh, say anything. Lifelong learning. Yes. Mahmoud, put your hand up. In biology, absolutely. You must include your A levels as well in that. A lot of people
Hello?
forget that. Hello, yep, can you hear me?
Yep, hi.
Yeah. Would you like to attempt the question?
Sure, I'll try my best.
Okay, go for it. So, why
Okay.
would you like to study medicine?
Okay. I'd like to study medicine for multiple reasons, ranging from personal reasons to clinical exposure later in my life, and also scientific reasons, for example, research that I've conducted myself. Starting with personal reasons, I'd like to study medicine because my mother actually had 4 C-sections. So she's had a lot of complications from it, and me having to go to the hospital to translate for her regularly. So it's been it's been nice to see how doctors build that trust with the patient, which is a core NHS value, especially empathy. And also having 4 siblings, it's been me having to take care of them has also showed me like how a doctor has to work with multiple people and how that's good. Towards my clinical exposure, I've done a month's work experience in Germany where I observed orthopedic surgeons, and that's like a career I'd like to go into surgery. So being able to see like the technical detail they had to do and like the patients and how they had to communicate and be part of a team also motivated me towards medicine. And seeing how they have to think under pressure. For example, in a surgery, anything could go wrong at any moment. So having to, solve a problem under pressure was something that I liked a lot because I like working under pressure. I've also done NHS work experience at my local hospital, where I was at my local ward, local cardiology ward. That work experience helped me see the teamwork aspect of medicine. The consultant having to do the general disciplinary meetings in the morning, where they give like a briefing into what's going to go on the day, who's going to be conducting ward rounds, and who's going to be seeing patients. It also helped me see the administration side of medicine. For example, the doctor I was observing was actually a foundation year doctor, and he had a lot of admin work to do, having to like having to see all the patient history on the computers and everything. And that also showed me a side of medicine I might have not known if I didn't actually do the work experience. So it's also helped me see, stuff that others might not see that, but I still think it's a great career. Onto the research side of things, I think medicine is a very scientific field. There's a lot of research that you could do, and it's like a lifelong learning journey. So I wrote a piece on sickle cell anemia on a national competition. It helped me understand the biological basis of the disease, but it also helped me understand how health inequality is in medicine. For example, with this disease, it's more present in Africa instead of Europe. So it helped me see how we might be able to improve funding within medicine. So it's also motivated me to be someone who could actually make a change. Also, I did an EPQ for a year on dopamine and how social media companies manipulate dopamine and affect our brain's reward system. So also seeing that scientific basis really motivated me to do medicine. Yeah, that's
Lovely,
pretty much
amazing
it.
answer. Very good,
Thank
very
you.
good.
Thank
Can
you.
I ask a follow-up here on why would you not want to be a nurse? Why have you not applied to a nursing degree?
Sure. I think nursing is crucial, just as other roles in healthcare, for example, physiotherapy or a radiologist or like a neuroscientist, like all these healthcare roles are very, very important. And without them, doctors can't really exist because, it's a team effort, it's a team job. So I would never underrole their role, but the side to medicine that I like that nursing might not have is the decision making involved. When observing orthopedic surgeons, they were the ones making decisions on what to do with the patient. It wasn't the nurses. So that element of making decisions really motivated me towards specifically medicine. And later in life, I want to go into pediatric surgery, which is a role where you need to be a surgeon, which is through a doctor. Also, another aspect towards why I want to be a doctor and not a nurse is because doctors, I feel like they're the ones who are giving the diagnosis. They're the ones who are like responsible for the patient, and that sense of responsibility I really like because it helps me. It helps me feel good, about medicine. But although nurses, they obviously have a lot of contact with patients and they have very crucial roles. For example, like giving dosages of drugs to patient and prescriptions. Like they have very important roles. But I just generally think that the aspect of decision making and being that leadership as a doctor is what truly motivated me. For example, now I'm the student council president and I own my own medical society, and being able to organize and make my own medical and make my own decisions for the team, it really motivates me to being a doctor and not a nurse.
Wow. Okay, I'm very happy with this answer. It's so detailed. Well done. You've got a lot of experience as well that you've included in your answer, and you've actually ticked most domains. So you've spoken about any extracurricular stuff that you've done, like you spoke about the medical society, any work experience that you've done. You've also included your personal own experience. And sometimes I say don't include personal experience, but I feel like you really included it quite well here and linked it to everything else. That's quite good. The only thing I
Thank
would
you.
include is also just make sure you're very specific to why doctor in the beginning, because you don't really want the follow-up question to why not a nurse.
Okay. Yeah. Yeah.
That way you can dodge that question because sometimes it can be a very difficult question. For nurses, they're more involved in the physical care of the patient rather than the diagnostic approach, because that's what doctors do. Even you can get why not physician's associate, and even then the prescribing responsibilities are a lot higher for doctors. So you must, of course, like you already did, that you acknowledge the importance of nurses, but just specifying why you don't want to be a nurse. Also, doctors are hyper specialized, so they can hyper specialize into absolutely anything, but it's very much limited for nurses and physician's associate. But overall, very good answer. Very strong answer as well. Yeah, good job.
Thank you so much.
No problem. Of course, I can't see your body language, but remember to use your arms and stuff like that. For me, my interest in medicine gradually developed. What dream was okay. Good use of MDT there. Good use of the work experience. I joined the PACE project. Yeah. Oh, also one thing was you mentioned pediatric surgery and when you want to go into pediatric surgery. Don't specifically specify a specialty you want to go into. Just say I'm thinking about a couple of options and the aspect of being a pediatric surgeon does really interest me. So don't specifically say I want to be this because it just shows that you haven't had too much exposure, if that makes sense.
Yeah, yeah.
It also reassured me to great answer. Well done, Ans. Well done. I would also include any A-level stuff that you've done. Can't really see it in there. And also any research that you might have done or read about too, because that's quite important. Anyone else have any questions about this question? It's very much personal and it can be very variable and they can cut you off beforehand. That's all right, because I'll just ask you a follow-up question. Can we recycle our question one from our personal statement? Yes, if they don't look at personal statement. If they look at personal statement and they see that you've kind of said the same exact thing, then panel interviews, they like really asking about personal statements. Some uni for MMI, they like to ask like a whole station on personal statement. Yeah, most unis don't really tend to see it before they interview. Okay, now we're gonna move. In MMI, do they ask you questions about personal statement? Can do. Has happened before. It's happened before. Okay. Sorry. Okay, next one. Anyone would like to interpret this graph? So graph question, it's an MMI station. And you just approach it like maths. Akalia, go for it.
Um, so the graph is displaying cardiovascular disease death rates over time in men and women and both of them. So on the x-axis, you can see the years they happen in, from 1969 to 2013. And along the y-axis, it shows the under 75 age standardized CVD death rate per 100,000 people. And you can see that at 1969, the men's death rate was a lot higher than for women, by around 250. And this decreases over time for both of them. And by 2013, it's lower than 200 and lower than 100 for women. and it's around 100 for both of them. So over time, we can see the cardiovascular disease has decreased for both men and women, and this could be due to education in the matter. So education about dieting and exercise and how people know more about what's in foods and things and how to regulate intake. They also know what proper exercise is, so knowing that they have to do a certain amount of exercise per week, that they have to eat certain foods to manage their weight and diet. And with cardiovascular disease, it this could also relate to any graphs about uh, diabetics or obesity because they're all very closely linked together. So if we saw a graph on those, they would probably show a similar trend in uh, decreasing over time.
Why do you think that the death rates for women is a lot lower than men?
I'd say that men tend to have higher metabolic rates than women do, and I'd say that maybe to fuel that, they tend to eat more, maybe, and that might be a reason why there was higher at the big there's is still higher. And also maybe if you look at social factors, women are always like presented in social media to be skinnier, and a lot of like toxic dieting factors have been introduced over the years. So maybe raising awareness about those could have decreased it. But since they are present, they that could be why cardiovascular disease is lower in women than it is in men.
Yes. And do you believe that this graph is a reliable graph or valid?
Um, it would depend on the sources for the graph because we can see at the bottom the source says BHF. However, we have to know if it includes data about everywhere, so all the countries, all the demographic groups in a country, all the ethnic groups, and that might vary. So for a low-income country, this could be a whole lot lower than it would be for a high-income country because high-income countries are often high in processed foods and foods that are higher in fats, which is the leading cause for cardiovascular disease. We also have to look at different ethnic groups so that genetically they could be more susceptible to diseases that other groups might not be. We also have to look at income for people. So if, for example, in England you have a lower income, you're more likely to go for ultra processed foods because they're generally cheaper than meals that you have to cook for yourself. So that might be a cause as to why it's like the sources might change the graph potentially.
Amazing. Well done. Yes. A very good structure. I'm very happy with that. And loads of different reasons on why the graph might be like that. So that's very, very good as well. So you spoke about the title of the graph, the X and Y axes, the intervals, and the overall trend, which is downwards trend. You can also say, men is blue, women's purple, and both is green. And the overall trend is that the cardiovascular disease death rates are going down over time. You must have some data manipulation. So you stated the years and the death rates. That's no problem. You can also do a percentage decrease if you're quite good in maths, or you can just take basically the obvious. So then we need to speak about whether this is a correlation or a causation, and this would be a correlation because there is no specific cause that we can identify from the X and Y axis specifically. So it's not a causation, it's a correlation graph. And we need to give reasons for why the death rates are decreasing, which you did. So it could be due to increased public health schemes and increased patient education and medical advancements. So we now know the risk factors for cardiovascular disease, whereas back in 1969, we didn't really know about these things. And the reason women are lower than men is because of the estrogen levels that women have is very cardioprotective in that sense. But you don't really need to get that right as long as you kind of give an answer or a reason to why you might think that might be the case, and there's no problems. Here, I'm not sure if you can see my mouse, there's a bit of an increase here. So that could either be an anomaly or it could be the year where, I don't know, a new fast food came out and everyone started eating that. So you can give loads of different reasons. Even it can be as wacky and as unique as you think it is. But you need to also predict how the graph might be if we were to increase it in terms of if we took the data in 2025. So in 2025, do you think the graph would increase or decrease? You can say both. You can say, whatever you believe will be. So it could be it will decrease because we have further education, or it could increase because of the cost of living crisis. Because of the cost of living crisis, people are opting for more fatty foods because it tends to be a bit more cheaper than buying fresh vegetables and fruit. So that could be another reason. Then in terms of the reliability of the graph, you spoke about the source and also the sense that we don't even know what country this is in. If it's in England, what part of England are we in? Because we know that places that have lower socioeconomic backgrounds, they usually have a higher cardiovascular death rate. The source is British Heart Foundation, which is quite reliable in the sense that they are a charity that focuses on cardiovascular health. And I know they have stratified it by sex and gender, but we don't know specifically about the ethnicities as well, because we know there are specific ethnicities that are at risk too. So overall, very good answer. I think it's very structured. You hit main points. Remember to speak about reliability without asking for a follow-up, if that makes sense. But yes, very good answer. Well done. I'm very impressed.
Thank you.
Oh Lord, that's good. Could you please enlarge image? Sorry. This is the image. Would it be okay to say maybe men had more exposure as more labor work before? Yes, you can. Any reasons, absolutely fine. As long as it provides the reason for why the graph is the way it is. It can be as wacky and as unique because you don't get marked down for that. You will get marked down if you don't try to attempt the explanation for the graph. Can you say treatments for CVD have gotten better, reducing death rates? Absolutely. That is one of the reasons why we've got a lot more surgical procedures and a lot of medications that we can give to people that can actually prevent them from having certain problems in the first place, like preventing the risk of stroke and stuff like that. What happens if you say something that isn't true scientifically? They won't penalize you because they know you're not a doctor. They know that not everyone's covered the whole biology curriculum. So you can just say that I'm just trying to think of any ideas, and I think that these could be the reasons why, or it could even be something quite unique, like blah blah blah. So you can really say whatever you think that the graph is really like that. It can be anything crazy. When you say medical advancements, do you always give examples? If so, what do you say? You don't have to give examples, no. You can just have a very general overview, because really what they're looking for here is more about the interpretation for the graph and whether you can provide some sort of reasoning. So if you say, okay, there's been an increase in medical advancements, such as more precise surgeries, new medications that can be administered to prevent heart attacks and stroke from occurring in the first place. That's all you need to say, because they know you're not a doctor, so they won't expect too much in terms of that. It's more about the structure. Have you talked about the title, the X and Y axes, whether it's correlation or causation, the trend, and why the trend is the way it is? Any other questions regarding the graph? No. So next question. Could you please tell me about the current issue of antimicrobial resistance? Who wants to go for that? Or you can put it in the chat. What do we know about antimicrobial resistance so far? What are the causes of antimicrobial resistance? Yes, overuse of medications, absolutely. So if you take antibiotics for a condition that is viral, like the flu, MRSI, yeah, absolutely. Not completing the full cycle of medication, you're right, yes. A lot of people don't finish their full course of medication because they feel a lot better during their cycle, or it's just too long for compliance. 2 weeks is quite a long time sometimes to take antibiotics. Misdiagnosis, yes, can do, yes. Yeah, random mutations, natural selection, overprescription. Yes, overprescription is a really big thing. The reason overprescription is quite a big problem is because during consultations, doctors only have 10 minutes for a consultation, and when a patient starts demanding for antibiotics, at the end of the day, we want to increase patient satisfaction, so a lot of doctors just end up prescribing antibiotics anyway. So now we have a lot more stricter guidelines on that. Using them for viral or common diseases, yes. A lot of people don't know that antibiotics are only for bacterial and not for viral. So the moment someone has flu-like symptoms, they just start taking it. If you got a chest infection from the flu, it's different. You can't take antibiotics. Buying low-quality antibiotics, yes, absolutely. Another reason that no one's mentioned is actually animals. So a lot of farmers use antibiotics to treat infections in animals. And when we consume meat from animals, we can actually start getting resistant strains from the animals too. So that can be quite a a big cause of resistance. So what are the ways that we can prevent resistance from occurring? Because antimicrobial resistance is a huge problem. It's quite a big cause of mortality in patients. When a patient has an infection that's not controlled or treated, it can spread around their whole body, and we can call them septic patients. We call it sepsis. And if you don't treat sepsis with antibiotics immediately, I think you have a 10-minute gap, then the patient will die. So it's very important that we're able to use as many antibiotics as we can. Can prevent antimicrobial resistance by preventing them, giving common, don't use the same type of antibiotics. And also, you can also culture the infection to see what specific antibiotic you need. Awareness through workshops or leaflets or posters. Yes, a lot of GPs have them. Collaborating with governmental and non-governmental organizations. Medications should be the last option. Yeah, it shouldn't really be preventative, no. Could you use monoclonal antibodies in a farm to prevent it from reaching our food? Good question. I have no idea. Not too sure about the animal side of things. Practice good hygiene and resistance. Yeah, absolutely. So number one is to educate patients on finishing the full cycle. Number two is by ensuring that doctors explain to the patients regarding it's only to treat bacteria and to stop prescribing it if it's not necessary. And the third one is we're not allowed to use certain antibiotics for animals anymore because we're trying to preserve the really important ones for humans. And checking prescriptions and moderation, absolutely, yes, that's another one too. So there's a concept that a lot of people don't know about, and I'm going to tell you guys, because if you use it in your answer, it will give you a lot of points. There are two types of antibiotics. You've got narrow spectrum and broad spectrum antibiotics. Broad spectrum antibiotics cover everything. Any organism that can cause an infection, it will cover anything. Narrow spectrum antibiotics is when it targets that one specific organism. Now, the problem is when you've got a patient coming into a consultation and they're feeling really ill, we don't really have the time to swab a patient and send it for cultures because it will take days for the results to come. So we just give them broad spectrum antibiotics. But the problem with that is broad spectrum also targets the healthy bacteria in our body as well. We have bacteria that is on our skin or inside our gut that we need to maintain homeostasis, to maintain the balance within our body. So we start removing those bacteria as well, and we can just grow even more resistant. Now, broad spectrum is quite useful in the sense if it was an emergency situation where you've got like an infection that's spreading very quickly, then you can administer broad spectrum. But the thing is, we need to move from broad spectrum to narrow spectrum as soon as we can. As soon as we know the organism, we can move to narrow spectrum. So the main part of that story is try prescribe narrow spectrum wherever you can and prevent prescribing broad spectrum wherever you can, because we can't necessarily delete the whole idea of broad spectrum because we still need it in emergency situations. If you go into the GP and you've got a cough and a chesty cough, they won't start asking you to cough in a container and send it off. No, they'll just give you a common antibiotic, and that can cause resistance. Relating to this, I have a question about PCOS, as I have heard it's becoming very common for women. Should contraceptive pills be taken, or does it have high risks? Can it be controlled without hormone pills? Yeah, there's a lot of guidelines on the NICE guidelines regarding the treatment of PCOS. There is risks of taking contraceptive pills. However, there is risks with everything. So it's very much a case-by-case decision, and it requires an MDT most of the time as well, because hormones are very difficult. They're very, very difficult, and the same treatment will not, like one treatment for one woman won't be the same as another woman. So you don't need to know too much about this. PCOS is becoming a lot more popular. The only reason it's becoming popular is in the sense that we have better diagnostic tools for it, and it's more widely realized. Same with endometriosis. How should we learn hot topics? Flashcards or just general notes? It can be anything. The thing with hot topics is you don't need to know too much, but you still need to know. If you want to make notes, you absolutely can. And I'm going to talk about a resource I've made to help with interviews. A lot of, I think we've got about 500 people that's using their website and everything. So I'll talk about that. So it'll be very, very helpful for you guys. But don't worry, you don't need to know too much, but also you do need to be aware of it. So you don't need to know too much stuff about statistics in general, because statistics are kind of hard to memorize. But if you do know the odd statistics here and there, it is quite impressive. Just a general question: how are MMIs similar or different to OSCEs? It's very different in the sense that OSCEs, every station is testing an examination or a patient history. So in a sense, it is like a circuit where you have different questions and different interviewers, but it's just the types of questions are very different. And OSCEs are for medical students and MMIs are for aspiring medical students. Okay, any questions about antimicrobial resistance? So you need to make sure you can define it, the causes of resistance, and how to combat resistance. Okay, next question. You're a doctor and a 14-year-old patient comes in asking for contraception. How do you approach the scenario? Any thoughts? Please put them in the chat. Akalia, you want to go for it?
Do I treat this like a role play or just saying
No,
what I
like,
would do?
yeah, just say what you would do. Yeah.
Okay. I'd ask the 14-year-old first, whether she was like what the situation was, first of all, whether she had a boyfriend or like if this was consensual and if she was being safe with it. If she is like committing the act, like I would check what is she taking the contraception for, because sometimes people take contraceptions for the wrong reasons. I'd also have to ask her like, are her parents aware of this? Does she need help like talking to them? Does she want to come in for like a joint appointment with her parents so that I can help her talk to them? Um, I'd also ask her what she understood about contraception, like what she thought it did for her. I'd make sure she knew the risk with contraception and with all of it, basically. I'd also have to make sure that she's aware the of contraception and everything and the risks involved, so that maybe Glick's competency could be applied if she understood, like if she's able to repeat back to me what I just told her, and if she's able to understand what I'm saying, then Glick's competency could be applied.
Yes. What other competencies can you apply other than Gillick's?
Fraser's guidelines.
Yes, absolutely. Yes, correct. Yes. Yeah, very good answer. So you're absolutely right. So when you have a patient that's quite young, the first thing to think about is safeguarding problems. So when you talk about safeguarding, you talk about age gaps, you're talking about abuse, you're talking about drug usage, and is the patient at any harm? And that should be the first thing that you should think about when you got a patient alone that's young coming to see you. The second thing is about capacity. In anyone that's above the age of 16, you can assume capacity for unless otherwise. But for children, you can never assume capacity. So you must test for capacity using the Fraser guidelines and Gillick's competence. By ensuring that they can understand the benefits and risks of the contraception and whether they can retain that information and explain it back. Now, it's very important to also use the ICE framework here, ideas, concerns, and expectations. Why do they want the contraception? Because contraception can be used for different purposes. It can also be used to regulate hormones and periods, so we can't assume why they want contraception. The concerns that they might have is usually side effects or any pain, and what do they expect from the consultation? Because sometimes they could have seen something on social media regarding contraception that's not right, and we need to solve another problem that they have instead of actually the contraception. So we check for capacity, be very empathetic, don't discriminate the patient based upon the age. The age of consent is 16 here, but that's not really the problem. The problem is whether the patient has capacity or not. Because when we're looking at the 4 pillars of medical ethics, we're thinking autonomy, does she have capacity? Beneficence, are we doing good by providing the contraception, which is usually right, which is usually good unless the patient does not have capacity. In that case, we will speak to the MDT regarding what we can do. Non-maleficence is the do no harms that links with maleficence, and justice is to make sure that we use the Fraser guidelines and the Gillick's competence to assess capacity in the patient and also not discriminating them and following the Equality Act 2010. So at the end of the day, if she understands everything, then we can definitely give her the contraception, safety net with advice saying if you have any problems, please come back to us. And that's really important because you're building patient rapport. If you were to break confidentiality here, which you don't need to do, you would be breaking the doctor-patient relationship and the patient won't come back to you, and they would probably go for even more like dangerous methods of contraception instead. So chat, it says possible complications, yes, background and safety, be aware, yep, check for possible signs of abuse, absolutely. Anything to do with children, check safeguarding first. And you never assume capacity, especially in children, so you would test for it. Fraser guidelines is to do with sexual health, and Gillick's competence is to do with anything in children. So if a child came to you asking for painkillers, you would use Gillick's competence. Whereas if a child was asking for contraception or abortion, you would use Fraser guidelines and Gillick's competence, because Fraser guidelines is to do with sexual health. Yeah. Any questions regarding this? It's a very common question. Yeah. Okay, the next question. What do you know regarding the problem of obesity in the UK? Are we responsible for reporting any crime? No. Depends. Sorry, I shouldn't have said no. But like let's say if a patient is using illegal drugs and they've told you that they're using illegal drugs, then you don't need to report them unless you believe it's a safeguarding problem. Because your duty as a doctor is not to check whether citizens are abiding by the law, but your duty as a doctor is to check for the health of the patient. So in that scenario, you wouldn't need to report them if there's no safeguarding problems. Crime, people will admit the crimes. People would, like 40% of your patients would have at least used drugs once in their life. We can't report all of our patients because that'd be breaking doctor-patient rapport, and then no one would come to see us again. And that's going to be a problem. Okay, anyone want to answer what the problem of obesity in the UK? Or at least put some ideas into the chat what you guys think. This is a very common question that likes to come up because it is a common crisis. I stands for ideas, concerns, and expectations. So when you've got a patient that comes into consultation for the first time, and we use this in medical school and we use it as doctors as well. I stands for idea. So why are you here? If you've got pain, what do you think is causing your pain? C is concerns. What are your concerns? You know, is it your side effects? Is it the pain that you're in? What exactly are you concerned about? And expectations is E. So E is for expectations. What do you expect from this consultation? Would you like us to prescribe you something? Would you like just for us to give you advice? What exactly is it? Increased use of processed and cheap food. Ultra-processed foods are cheaper alternatives, yes. More evident in children and younger adults. Yeah, obesity can be from carcinogens such as processed food. Absolutely. Less access to the gym or exercise due to distance. Yes, yes. North-south divide. Demanding workload in daily life. Yeah. In situations in which an under 16 is competent but wants to participate in life-ending treatment. What do you mean life-ending treatment? That would be illegal because euthanasia is legal. Less education about exercise. Yes, absolutely. Why is obesity a problem? A lot of people don't know why. Why is obesity actually a problem? Increased CVD, yes. And why is that a problem for the NHS specifically? Absolutely, yes. We unfortunately it costs billions and if not millions of pounds to treat obesity-related illnesses. Risk factors for strain on NHS resources, yes. Lovely, yes. Mahmoud, you have your hand up.
I just wanted to answer it.
Yeah, go for it. Absolutely go for it.
Okay, so I'd say obesity is it's a major public health issue, especially in the UK. It has a lot of effects on the individual, but also as a society as a whole. For example, on the NHS, it causes many issues. For example, financial pressure, as you said, the NHS spends billions treating obesity. It's a chronic condition, so it's long term. So there'll be an increased workload on GPs and doctors because they'd have to have more appointments, they'd have to have more prescriptions of certain medicines, which will obviously increase the funding, but it'll also increase the workload on doctors. And as you know, they're already very busy. Also, hospitals might need specialized equipment for obesity. For example, they may need imaging that a normal person can use, but someone who's obese can't. It could also increase the waiting list. For example, in the UK, the NHS already has a very long waiting list. People wait a lot of months just to get an appointment. So by adding another chronic condition, obviously the waiting lists will increase a lot. And in regards to the population, obesity is more present in deprived areas within England, areas that may have low economic stability. Maybe that's because of poverty, and then they'd have to be buying foods that are cheaper, which are normally more processed and, aren't as healthy, hence why people might have obesity. Obesity might also be other reasons. It might also affect mental health of an individual. It might decrease their low self-esteem or make them depressed or other mental issues. Then I think the NHS can there's a lot of solutions that the NHS can do that might improve it. For example, they might make the government undergo behavioral interventions. They could make schools give policies, or they could make schools promote the idea of a healthy lifestyle, which could prevent obesity. Another way is by supporting families or children who are from deprived areas. They could support them, whether it's financially or environmental aspects or other things. And also, we can, there's also more government things that could happen. For example, you could tax food or drinks that have a large amount of sugar that might link to obesity, or you might restrict advertisements that are linked to junk food. But yeah, those are the things you can do to like prevent obesity.
That's a perfect answer, Mahmoud. Very good. Well done. It's very holistic in the sense that you've just spoken about the psychological and the sociological impacts of obesity too. Absolutely right. So when we're speaking about obesity, you must define obesity first. So in the sense that obesity is like a BMI over 25 or something. You can just say it like that. What is obesity? Because the BMI scale is not necessarily the best scale. It can be height to waist ratio instead. So you can say obesity is when a patient has a BMI over 30. That's what obesity is, 25 overweight. And obesity is a huge problem because it can increase the risk of cardiovascular diseases such as stroke, heart attacks, can increase your risk of type 2 diabetes, even depression, or any psychiatric disorders. And 1 in 4 children in schools are obese, which is a large amount. And that puts a lot of stress on the NHS because we're treating illnesses that could have been prevented in the first place due to the fact that individuals are obese. Now, it's really difficult because there are different causes of obesity. It's not just like just eating too much or not exercising. You've also got genetic causes of obesity as well, such as the Prader-Willi syndrome. And the Prader-Willi syndrome is when you have this loss of function of a specific chromosome, and that just means that you're constantly hungry even if you eat, and that's a genetic condition. So we can't necessarily prevent that from happening, but we can maybe treat it. Now, the way that the government has tried to tackle obesity is by ensuring that there are more PE teachers in schools and extracurriculars in schools that can cause students to move about a bit more. They've also looked at the lunch menus in schools to ensure that it's very healthy and balanced. We also have done the sugar tax, where we have increased the pricing of sugary drinks and foods, but that hasn't necessarily worked anymore because the fact that people are just more than happy to buy their favorite drink or food for about 5 or 10p extra. And the thing with sugar tax is because of the cost of living crisis, a lot of people rely upon fast foods and cheap items to survive. And because you've increased the pricing of those items, some people won't even eat because of the fact that they can't afford it. So because of the cost of living crisis, a lot of people are at increased risk of getting obese, but also that they're not able to afford any food on their plate because of the sugar tax. So it's a bit of a two-way scenario. They've also done Couch to 5K, which is when you're teaching individuals to run 5K in the span of 9 months, 9K in the span of 5 months. And also just education. A lot of people, once they're educated about the risks of obesity, they do try and change their health habits too. But it's very difficult, especially if you don't live in an area which is very green or have very big access to gyms. It's very difficult for you to access those services. And also even like a walk in the park, if you're not from an area that has low pollution levels and it's very polluted and it's not green, it's very difficult for people to go and exercise outside too. So it's definitely multifactorial approach that we have to take. But Mahmoud, very good answer. I can see that you've really practiced, so well done. Lovely. Any questions on obesity? It's a very common question that comes up. Yes, Mahmoud?
It's not letting me type in chat.
What?
Yeah, there might be like some issue.
Can everyone else type in the chat? No?
It's just me, I think.
Oh. It's okay, you can put your hand up. If the chat's working, can someone just put something in the chat to make sure that it's working? Yeah, okay, fine, it's working. Perfect. It's working now. Okay. Yeah, any questions? Okay, we're moving to our last scenario. Oh no, actually no. 2 minutes. No, second to last. So a role play scenario. You are a doctor who's breaking bad news to a patient who has been diagnosed with type 2 diabetes. So I want someone to answer this and explain how they would approach the situation. Rashma, go for it.
So in this role play situation, first I would talk to the patient and just ask them how they're feeling today, and if like just how their day has been, so like I can kind of get to know their emotion a bit, like in the exact situation. And then I would ask them first what they're expecting from the talk that we're having now today, so kind of what they want to know. And then I would explain my role. So I'd introduce myself. Actually, I'd do that before asking what they're expecting. So I'd say, if I'm a doctor or if I'm a medical student, I'd say that. And then I'd say the purpose I'm there for, and just introduce myself. And then after that, I'd ask them what they're expecting from this consultation today. Um, and then I would really empathetically break the bad news. So I'll say that unfortunately, our test results showed that you have type 2 diabetes. And then, so right after doing that, I'd ask them how they feel and if they want a minute or two to kind of like process this information. And then I will kind of speak to them empathetically and kind of make them feel better by saying all the points and the improvement, or the like the kind of the medications, or the diagnosis, helping kind of medications that we in the multidisciplinary team have decided. So we'll talk about that. And then I'll ask them if they're comfortable with following this procedure, or if they want anything else to be added, or any concerns they have. And I will give them an opportunity to ask any questions before ending the consultation.
Yes, lovely. Yeah, yep, great structure. Yeah, so you followed the Spikes framework, which is the framework to use here. So remember, right at the beginning, you must confirm the name and date of birth of the patient. That's the only thing that I think you missed. So that's completely okay, because you don't want to be saying that someone's got type 2 diabetes to the wrong patient. That can end bad. So what you do is you bring them to a private room, in a confidential room, you confirm the name and date of birth, you explain who you are, and just build some rapport. How are you today? What have you been up to? Also ask them, do you know why you're here today? Do you know what about the tests that we've been doing? A lot of people don't really understand what tests have been done. So you can explain, okay, we've been looking at your bloods, we're just checking for any sugars or anything like that. You just must explain to the patient what's been happening to try and decrease the shock. Then after that, you say, unfortunately, I don't have good news for you, which is a warning shot here. And then you ask 3 questions. Number 1, would you like to know the news? Number 2, if you would like anyone in the room or out of the room, because that's important for confidentiality and support. And number 3 is, how much would you like to know? Some people don't want to know a lot about their diagnosis, and that's absolutely okay. We just have to tailor our information style to the patient. Now, after that, we break the bad news, ensuring that we don't use medical jargon. So unfortunately, you've been diagnosed with type 2 diabetes today. You don't say you've been diagnosed with diabetes mellitus, which is the cause of blah, blah, blah. No, very straightforward. And then you ask if they have any questions, reassure them, ask if they want any tissues, if they're crying, refer them to any support, but you must work within your competencies. If you don't work within your competencies, it's very unprofessional. So if they ask, am I going to die from this? You can't necessarily say no. You must be very honest. I can't answer that question for you. I'm going to have to ask a senior doctor. Then you summarize the consultation, any questions, and what interviewers really like is asking if they would like to arrange transport back for the patient. Because sometimes if a patient has driven into the hospital and they are not mentally ready to drive back, that's an issue for their own safety and other road users as well. So we can arrange transport back too. Do you ask for their name and date of birth? Yes, you can. What if they don't want to know their diagnosis? Then we can reschedule it. Because some people, like for example, like let's say you've got an interview or you're getting married the next hour and you don't want to be diagnosed with something bad. That's absolutely understandable. So you can just reschedule the consultation. Debrani.
Yeah, I was just asking because diabetes is so common nowadays. Can you add a line to the like role play saying that it can be controlled with like diet and exercise?
Yes,
Or
you
is
can.
that
Yeah, you can. Because diabetes is a topic that most people are educated on, you can definitely use your own knowledge. It's just sometimes they say that you've diagnosed the patient with cancer and you won't necessarily know. what to say. So if
Yeah.
it's something like diabetes, then yes, you can. That's impressive, yes. But what if that's harmful to their health? Like, say if it's a worse diagnosis than diabetes, as in if they don't want to know the diagnosis. If they don't want to know the diagnosis, they have the autonomy to not know. So we have to respect their preferences. Unfortunately, I have bad news for you. They should kind of know what's coming at that point, because we explain what tests have been done and what we're looking for. And if we say that we've got bad news for you, they should know what's coming. Yeah. Okay. Perfect. Lovely. So now we're on to our last question. You're a doctor and a patient tells you that they're using illegal substances on a regular basis. I think I actually answered this question in the chat a while ago, but so in the chat, what would you do? Number one is, would you report the patient or not to the police? Because that's the biggest problem here, that people know. Why do you not report to the police? Would I suggest treatment options if they don't want to know the diagnosis? If they don't want to know the diagnosis, you're gonna have to reschedule the appointment entirely. Nope. Doctor-patient trust is broken. What else? Breaks confidentiality. Yep. Maintain doctor-patient relationship. Absolutely, yes. The GMC says that you don't have to report unless you would believe there is a reason to report. So here, if you believe like it's a mother, newborn child, can't take care of the child anymore because she's constantly using drugs, then fine, you can report. And it's a big problem because a lot of drug users, they never actually come to the hospital in the first place. And it takes a lot for them to come into the hospital. So if they come into the hospital, you're breaking that 1% of trust that they have in you, because they really need to access the hospital. Because if you're using drugs, you're at an increased risk of loads of different things. So you really want to ensure that you maintain that patient-doctor relationship wherever possible. You can refer them to rehab. Yes. So in the situation, it also depends, do they want to stop or not? Because if they don't want to stop, there's no point in us referring them to rehab, because they're not going to use the service and it's going to be a waste of their time and our time. And we could have referred someone else that would have used the service as well. Because remember, we're very limited in our resources. So if they don't want to stop, then what we can do is we can explain, why they're here today. Is it because they're in pain or something, or they're dealing with the side effects of the drugs? Then we can treat those conditions and just explain the benefits and risks of taking drugs. Because I know there are benefits such as euphoria and feeling good, but you need to explain and educate the patient on the risks. But if they still want to continue, that's up to them. We can only be educational in the sense that, this is the risks. How are you using the drugs? Are you sharing needles? If so, I would really recommend if you use new needles and whatnot as well. So you can educate them how to do it properly. But if the patient wants to stop, then you can do whatever you can to help them stop. Jabrani.
Yeah, I was asking regarding this one. Suppose the patient is like self-harming them, or like there's visible like signs of abuse on their body. So like what would you do then?
Visible signs of self-harm.
Yeah, because of like drug use, if they admit that that's the case, then what
Yeah.
would you do?
So once we start seeing self-harm, it becomes a bit of a psychiatric issue, because we need to start doing a risk assessment on whether the self-harm is going to become to the point of a suicidal activity. Now, if that is the case, we just do a risk assessment in the sense that, okay, do we feel like the patient's at risk of themselves? But usually they won't ask you too much about that, because they know that you're just like students just trying to get through the interview. So they won't ask about that, because like even medical students, like it's a lot of training for us to ask those questions. So really, if you feel like there is any abuse at the patient, like, or they are at risk of something, let's say it's a child here, they're using drugs, and you believe that an adult is exploiting the child to selling drugs, then you can report and break confidentiality, because you feel like there's a safeguarding issue there. If you think there's a safeguarding issue, or if you think there's a slight concern, you can raise it up to someone else. Yeah.
Okay.
Yeah, better safe than sorry. But there's no point in reporting the patient if you got no problems with them. Because really, like when we ask about patient history, whenever I ask about patient history to my patients, I always ask them, have you ever used drugs before? And most of them say, yeah, I've used it once or twice. We can't report every single patient. It's not possible. Then no one would come back to us or trust us ever again. So that's a problem. So yeah, the GMC, we're doctors. We look at the health of the patient and not the legality of things. Any questions? No. So someone asked about how to prepare. So let's go how to prepare. So a lot of people in the call right now either have interviews or don't have interviews. And it's very important that if you have not prepped because you have not got an interview, you must start prepping tonight. The reason being is I have had this year alone so many people come up to me and say, listen, I've got an interview and it's in 1 week. am I cooked? Am I do I even have a chance of passing an interview? So you must start preparation now. It doesn't matter if your UCAT is low. It doesn't matter if you're not expecting an interview, because usually the unexpected happens. And when you get an interview, it's about a week in advance, 2 weeks in advance, and you can't ask for another date. So it's very important that you start preparing for your interviews now. It's very important that when you start interviews, you don't do 5 hours a day, you stagger it, because you don't want to burn yourself out. So you do a couple of maybe 30, 40 minutes every single day. And then when you get the interview, you can do a lot more. Now, a lot of people ask me, how much do I need to know? You can't answer interview questions without knowledge, and you can't just have knowledge and not answer interview questions. It's a mix of practice and knowledge. So it's very important, especially with hot topics like antimicrobial resistance or NHS challenges, you need to be educated on that, because they will know if you don't actually understand the challenges that NHS is facing or any hot topics. They won't ask you anything out of the ordinary that they think that students wouldn't know. It's very important that you're very aware of the challenges that face medicine at the moment, because that shows your wider awareness. Feedback is even more important, because there's no point in speaking to yourself in the mirror or speaking to friends and family, and if you don't get that feedback is where your improvement really begins. If, let's say, you've done a question and you believe, and someone gives you feedback saying, you missed out this, you missed out this, that is your cue to redo that question again, implementing that feedback. And trust me, this works. You know, I've tutored over 400 students, at least one, like every single one of them had at least one offer, with loads of them scraping all four offers. So feedback is even more important. Timing yourself is even more important. There's MMIs and panels. MMIs, you should be speaking for about 5 to 6 minutes. If it's a panel and you're speaking for 5 to 6 minutes, you're going to get cut off very, very quickly, because panel is usually 2 to 3 minutes. And it's also important to ensure that the style of interview that you have, you are prepping towards that style. For example, for a panel, you don't tend to get role play. You don't tend to get graph questions, whereas in MMI, you can get anything possible. In panel, they're more likely to ask you personal statement. Don't worry, I'll go through that, and don't worry. Go through personal statements. It's very important you do so. Then make sure you cover common questions encountered. That's really important. When a lot of people come to me, like someone just said in the chat, there's 3,000 questions from an interview book. You don't need to practice 3,000 questions. Every single year, there are common questions that come up every single year. There are some questions like, tell me about a time where you've done something, or why this university. That is guaranteed to come up. If you don't get that question, I'll be very, very surprised. So it's important that you narrow down the amount of questions that you're preparing for, because there are some questions, like Oxbridge questions, that is very difficult to prepare for, because they can be absolutely anything. But if it's a normal MMI or a normal panel interview, you can absolutely prepare for what's about to come. And in the past 3 years, I've never heard of anything that I've been shocked myself. Rashma, sorry, go for it.
Sorry, I was just going to ask, so you go to Keele University, right? And so for Keele University, do you have any specific advice, like when preparing for Keele interview? Because I know that they look at personal statements. So because for some of my questions, I recycled my personal statement. I can't really do that for Keele. And just in general, do you have any like tips for Keele medicine interview?
Yeah, so the advice I'd give is actually look on the official university website, because Keele especially gives you a lot of interview guidance. When you get an interview, your university will give you a lot of guidance on what you need to know and what you don't need to know. And also the guidance changes every year. So the tips that I would have given someone last year is not necessarily the same tips I would have given someone this year. But really, if you prepare for the most common questions for any interview, you will be fine university-wise. How do I actually start preparing? I don't want to go through that. Are there going to be any more sessions? MedDent does a lot of free sessions, and hopefully I'll be back to do more talks. So remember, personal statement is very important. So I'm sure you guys have seen, like, what is MedReady Go? I'm putting labels everywhere. What is this? So a lot of people go through about 1 million websites trying to figure out, what do I need to know? Finding information from about 1 million websites as well. So over the summer, I created a website where I created and handcrafted around 200 stations of very, very common interview questions. That includes role play, that includes graph questions, that includes ethics questions, that includes hot topic questions. Now, the reason that this is so special and unique is that you are able to practice out loud through your mic, and you will receive feedback almost instantly through the code that we have done. So we have got over 200 stations, and every station you can specify the timing as well. You can specify if you want 5 minutes, 6 minutes timing, because depending on the university, and you start speaking like the real interview. You start speaking because you need to practice speaking and getting the feedback. So once you started speaking, you will get feedback, you'll get an overall score, and the best thing is you'll get feedback on what you have missed out and what you have included. You also have a full walkthrough of each question. So that's a mark scheme of what you need to know and what you don't need to know. And I have made sure that all the common questions are on the website, because a lot of people ask me, do I need to buy this book? Do I need this? Do I need this? How many questions? There's infinite questions. When you think about it, there's not infinite questions. You can really narrow it down. And you want to ensure that your prep is high quality prep, that you're not wasting your time, especially with the amount of time that you have. So we also have a completely free. There are so many free stations on the website, so please do try it out. We've had so many users try it out, and they're absolutely enjoying it. We can see, and we've got a free interview guide as well, please, which you can download. It's got a lot about the structure of everything too. So the website is called MedReadyGo. Please have a go. If you have any questions as well, you can feel free to contact me about the website. But I've tried to make your life a lot easier, because I know that my life was very hard, having to go through so much stuff. There are so many free stations, Debrani. There's so many. We also have university-specific MMI mock circuits, which I've tried to code as well. And that's very good in the sense that it's like a real MMI circuit where you just continuously answering questions, and it's all different. So thank you for listening. Does anyone have any questions? Please provide me with some feedback about the session as well, so I can come back. And also, I can send some resources that I have as well in terms of structure or anything I have that would help you guys. So please do fill out the feedback form. But any questions, anyone? I'm really happy to answer any questions. How do you actually start preparing? I'm not sure how to. So how do you start preparing is you just go to the deep end. You basically dive right into the questions, see how you're doing, see what you need to improve, see where the gaps in your knowledge are, and start learning about things. So for an example, hot topics. If you're answering a hot topic like obesity, you should be able to sort of form some sort of reasoning in your head about obesity. But things like antimicrobial resistance, if you're going into the question and you have no idea what it's about, that's your time to stop, look at the mark scheme, what does the mark scheme say, and then try. Because you must educate yourself on the topic before answering. It's very, very important. So you start answering questions. Just go for it. Sky's the limit. Any more questions? We're everywhere on social media as well. Yeah, so for certificates, you need to fill out the, I can pin it, the link on the chat. And for any resources, and also for my own knowledge as well, because it's really good to get feedback, if you could fill out this QR code too, that'd be great. Any other questions? Also, I'm very glad that you feel more confident. Very important. Can you please upload any resources that are free in this chat? Yes, I can. It just won't let me because of the size of the file. Some of the files are kind of big. But yes, I need to ask my tech people as well. Yeah. If you can. This is the QR code. No problem at all. So that's the QR code. Yeah, I can also upload it into the thing, into the chat. This is our website as well, where you can start practicing. It gives you a step-by-step thing on what to exactly do. We have so many stations to practice. There is me as well. And we've got a lot of feedback on the website too. So really do try and utilize that as much as possible. We've got a lot of blogs there as well, if anyone finds it quite useful. Any questions, guys? You will ace your interviews, I promise you. With practice, absolutely. Yes. There are loads of free stations on the website. Do you have a document of info? Yes, that's the interview guide. But what I've done instead is, because instead of having a huge document full of information, every station that I've created on the website will have its own mark scheme. Yep. And we've also got the unit-specific MMI circuits, and if it's Oxford, we've got one of those as well. We've got dentistry stations, so we've tried to cater for everyone. But I'm just trying to make your lives a lot easier, because it can be quite hard. Do you do one-to-one tutoring? Not anymore. I used to, but I don't really have the time anymore because of medical school. So I tend to do group webinars instead. So if you go to our website and you can sign up, we can email you if you'd like. And we have weekly webinars where people practice live interview questions, and that's really helpful because a lot of answers are so amazing where you can literally take points from other people's answers. And trust me, like I know not a lot of people answered in this session, but a lot, like everyone's answering. So it's really important for confidence building too. If you sign up the QR code, yes, the session is done. We can ask you about that, yeah. So every week. And I do loads of free webinars too, because at the end of the day, it's to help students, which I think is very important. Any other questions? Please can you link your interview guide? Yes. So give me a second. So if you look at here, there should be a button here, interview guide PDF downloads. If you press that button, it should give it instantly. We've got a lot of people pressing on the leaderboard as well. But yeah, we've literally got so many stations on here, and we've put it to different categories too. Any other questions? No problem. Working this one.